Imagine going into surgery to restore your body. Maybe it's to fix a painful pelvic organ prolapse, or maybe to recover after severe childbirth trauma.
Right, or even undergoing gender-affirming reconstruction.
Exactly. You go under the knife with the expectation of relief, only to realize months later that your own body's healing process has essentially turned against you.
Yeah,
It creates a complication that is somehow worse than the original problem.
it's a completely devastating reality for a subset of patients. I mean, the intervention meant to bring functionality and comfort ends up completely obliterating them.
And that incredibly complex, heavily loaded medical reality is exactly what we are diving into today. So welcome to the deep dive.
Thanks. Yeah, today we're drawing on a massive stack of diverse sources to answer one incredibly specific, high-stakes question.
Can surgical tightening be revised?
Right. When a vaginal surgery designed to tighten, support, or reconstruct fails, can it actually be fixed?
We have so much ground to cover. We are looking at clinical guidelines from the Cleveland Clinic and the NHS, plus specialized surgical insights from cosmetic pelvic centers like Miklos and more.
And, we're also pulling peer-reviewed data from the journal Translational Andrology and Urology.
It's a lot.
It is a vast, highly technical
Yep.
array of literature, yeah. But every single source converges on navigating this specific life-altering surgical complication.
Okay, let's unpack this. Vaginal tightening procedures, whether we're talking about a vaginoplasty to tighten the internal canal or a perineoplasty focusing on the opening, they happen all the time.
Oh, constantly. Along with transvaginal mesh repairs to physically hold up prolapsing organs.
Right. But before we look at how to fix a botched procedure, I'm just trying to visualize the mechanics of the failure itself.
Sure.
If the explicit goal of the original surgery was to make the area smaller or tighter, how does it end up completely non-functional? Like, is the body just overperforming the surgeon's instructions?
Well, if we connect this to the bigger picture, we run into what the medical community considers the over-tightening paradox.
The over-tightening paradox.
Yeah. The very thing the surgeon sets out to achieve is exactly what triggers the structural failure. Let's look at perineoplasty, for instance.
Okay.
The surgeon removes tissue and sutures the area to decrease the diameter. But if the excision is too aggressive, or if the patient's biological healing response kicks into overdrive, you develop introital stenosis.
Wait, meaning the entrance gets way too small.
It doesn't just get smaller, it becomes a rigid, unyielding barrier that completely rejects any natural elasticity.
Oh, wow. It's like taking a tailored suit and taking it in so much that the fabric actually tears when you try to sit down.
That is a perfect analogy, actually.
But I'm looking at the NICE-E guidelines, the National Institute for Health and Care Excellence, and is it just a structural issue of the skin being pulled too tight?
Not always.
Because some of these prolapse surgeries involve introducing permanent foreign materials, right? They detail some pretty severe outcomes involving transvaginal mesh kits.
Oh, absolutely. The Apogee and Perigee mesh systems are prime examples of that. These are synthetic hammocks surgically implanted to suspend failing pelvic organs.
Right.
But the clinical data reveals a startling biological reaction. The body doesn't just passively accept the mesh.
It fights it.
Over time, that synthetic material can actually contract and shrink inside the body.
That sounds awful.
It is. And when that mesh contracts, it violently pulls on the surrounding vaginal tissue. The result is a physical shortening of the vaginal canal, focal tenderness, and severe chronic pain.
Because the mesh has essentially morphed into a rigid internal band.
Exactly.
It makes me think of pouring industrial superglue over a rubber band. I mean, the glue might hold things in place, but it entirely destroys the fundamental elasticity that the system requires to function.
Right. The structure is locked in a way it was never designed to be.
But what I want to understand is the body's role in this. Is this purely a mechanical issue of the scar tissue and the mesh physically restricting movement? Or is the nervous system actively fighting the surgical site?
Oh, the nervous system and the musculature are absolutely at war with the surgical site. To the body, surgery is not a therapeutic intervention.
Right, it's trauma.
It is a massive, violent trauma. And the pelvic floor muscles react to severe trauma by going into a chronic defensive spasm. It is a biological phenomenon known as muscle guarding.
So the muscles just lock down to protect the injured area and they just refuse to release.
Completely. And while the muscles are locked down, the body is aggressively laying down collagen to heal the surgical incisions.
Which becomes scar tissue.
Yeah, and in the vaginal canal, this collagen deposition frequently spirals out of control. It forms these dense, restrictive, hypersensitive scar bands.
Wow.
The natural biological distensibility of the mucosal tissue is effectively erased.
So you have a surgically narrowed opening compounded by involuntary muscle spasms, walled in by unyielding scar tissue. The sources from Miklos and Moore are incredibly meticulous about how they diagnose this because they emphasize that the pain isn't just a generalized ache, right?
Right.
The location of the pain actually acts as a roadmap to where the surgery failed.
Yes, the clinical distinction between entry pain and deep pain is paramount for a surgeon mapping out a revision.
Okay, break that down for me.
Well, entry pain, which patients describe as a sharp, burning, stinging, or tearing sensation the second any penetration is attempted, strongly indicates a perineoplasty failure.
Like introital stenosis.
Exactly. Or localized hyperscarring right at the entrance. It's a surface-level barrier failure.
Whereas deep pain, like a feeling of hitting a literal physical wall deeper inside the canal, points to an entirely different anatomical failure.
Spot on. That suggests an over-tightened posterior vaginal wall or severe vault tension, especially if the patient had a prior hysterectomy.
Or it points to that contracted transvaginal mesh we discussed earlier, pulling deep within the pelvis.
Right, exactly.
So, what does this all mean? If a patient is sitting in a doctor's office with these symptoms, their body is traumatized, their pelvic floor is locked in a defensive spasm, and their internal tissue is bound up in rigid collagen bands.
It's a very difficult place to be.
Do we jump straight back to the operating table? I mean, it seems incredibly counterintuitive to say, let's fix this trauma by putting you under anesthesia and cutting you open again.
Taking a scalpel to that environment literally feels like throwing gasoline on a fire.
Right.
And the consensus across the clinical literature completely validates that hesitation. The journal Translational Andrology and Urology leaves absolutely no ambiguity here.
Conservative management first.
Yes, conservative management must be exhausted first. You do not immediately reach for the scalpel to fix a scalpel's mistake.
Because the goal is to rehabilitate the tissue, not inflame it more.
Exactly. You want to avoid another massive inflammatory response at all costs.
But looking through the actual protocols for this non-surgical route, it is staggering what is asked of the patient.
It is. The sheer volume of labor required to manually rehabilitate this tissue is basically a part-time job.
I was reading about the dilation therapy. We are not talking about a casual stretching routine here.
No, not at all.
Oh.
The cornerstone of conservative rehabilitation is intense dilation therapy.
Right.
For a patient who has developed severe stenosis, whether from a botched cosmetic tightening or a complication following a gender-affirming vaginoplasty, reversing that rigid scar tissue can require upwards of 2 to 2.5 hours of active medical dilation every single day.
2.5 hours every day.
Every single day.
If you factor in a normal 40-hour work week, commuting, cooking, taking care of a family, finding a continuous, uninterrupted block of time to slowly, manually stretch out hypersensitive scar tissue seems almost impossible to sustain.
It is incredibly demanding, and dilation alone is frequently insufficient when you are battling dense, mature surgical scars.
So what do they do? Just push harder?
No, they have to augment the mechanical stretching. Clinicians rely heavily on localized pharmacology for this.
Okay, like...
The primary weapon here is triamcinolone, which is a highly potent corticosteroid.
And the mechanism there isn't just a lubricant, right? The steroid is actively changing the biology of the scar.
Oh, absolutely.
Yeah.
It is fundamentally altering the cellular environment. Surgeons inject triamcinolone directly into the rigid bands.
Ouch!
Yeah, but it suppresses the localized immune and inflammatory response. And by shutting down that localized inflammation, it forces the body to halt the overproduction of collagen.
Which gradually degrades the rigid fibers.
Exactly. It softens the scar tissue so the dilators can actually do their job.
The literature also points to a very specific hormonal intervention, especially for patients who are postmenopausal or just have naturally low estrogen levels.
Yes.
Applying topical vaginal estrogen seems to be a non-negotiable part of this therapy.
Estrogen is critical because of how it dictates cellular behavior in the vaginal mucosa. Topical estrogen directly stimulates glycogen production and increases local blood flow.
Plumping up the tissue, basically.
Right. It transforms thin, fragile, easily torn tissue into a robust, pliable matrix that can actually withstand the mechanical stress of dilation.
Got it.
You add that to intensive pelvic floor physical therapy to neurologically retrain the muscles to stop guarding.
And heavy perineal massage to manually break up surface adhesions.
Exactly.
But reading the Translational Andrology and Urology paper, there is a brutal psychological reality to this regimen that we have to acknowledge.
Oh, completely.
You are asking a patient who is already experiencing severe tearing pain to subject themselves to a multi-hour routine that inherently involves pushing against that very pain barrier.
It is a profound psychological catch-22. I mean, the
Yeah.
natural human physiological response to burning pain is withdrawal,
Right. And when the pain becomes too much, the patient inevitably skips a dilation session.
which is completely understandable.
But that allows that hyperactive scar tissue to immediately begin shrinking and contracting again.
Yes. So the next time they try to dilate, the stenosis is worsened. The entrance is narrower, and the pain is significantly sharper.
It is just a vicious, demoralizing loop.
It really is. And the literature emphasizes that any underlying behavioral or psychological conditions can completely derail this process.
Like depression.
Yes, if a patient is managing clinical depression or navigating executive dysfunction associated with ADHD, demanding flawless daily adherence to a monotonous, highly painful 2-hour physical therapy routine is practically guaranteeing failure.
Which brings up a massive takeaway for anyone listening who might be navigating complex medical interventions.
Right.
If a primary procedure fails, a second procedure is almost guaranteed to fail for the exact same reasons if you haven't fundamentally altered the environment.
Absolutely. You have to optimize the hormonal balance, calm the nervous system's pain loop, and realistically address the psychological barriers to compliance before you even think about the operating room.
Because if the tissue cannot heal correctly without surgery, it certainly won't heal correctly after another invasive trauma.
Spot on.
But we have to cross that threshold eventually, right? When the stenosis is so severe that 2 hours of daily dilation and localized steroid injections simply cannot physically pry the tissue open,
Right.
when penetration is structurally impossible, surgical revision steps in as the absolute last resort.
That is the line of demarcation where conservative therapy ends and highly complex reconstructive surgery begins.
And the sources make it clear that a revision isn't just surgery part 2.
No, not at all.
If the first surgery was like trying to remodel a house, revising a surgery is like trying to renovate a house where the previous contractor destroyed the blueprints, rerouted the plumbing blindly, knocked out the load-bearing walls, and covered the entire mess in solid concrete.
The anatomical landmarks that a surgeon normally relies on are entirely obliterated.
Wow.
Yeah, the normal tissue planes, the natural separations between the vaginal wall, the bladder, and the rectum are completely fused together by a solid block of scar tissue. Even the blood supply has been entirely rerouted by the previous trauma.
So how do you even approach that? I mean, my layman's instinct would be, well, the problem is that it's too tight. Just go in with a scalpel and aggressively loosen everything up. Cut the tension away.
And that instinct is precisely what the specialists at Miklos and Moore caution against.
Really?
Yeah, the philosophy of a successful revision is not about arbitrary loosening. It is a highly calculated restoration of functional balance.
So you can't just cut it all away.
Right. You have to meticulously release the restrictive scar tension to increase width, but if you release too much, you completely destroy the pelvic support.
Oh, and send the patient into a massive organ prolapse.
Exactly. It is a razor-thin margin of error.
Let's look at the mechanics of excising that transvaginal mesh, because this isn't like pulling a splinter out of a finger.
Not even close.
The body's tissue actively grows through the microscopic pores of the synthetic mesh, right? It integrates it directly into the pelvic floor.
Yeah, the mesh essentially becomes one with the patient's anatomy. To remove it, the surgeon must painstakingly dissect the mesh away from the vaginal wall
And navigate deep into the pelvis to divide the fixation arms anchoring the hammock.
without accidentally slicing into the bladder or the bowel.
Yeah.
And the success rate on the first attempt is sobering.
I read that in the NICE guidelines, they cite a 58-woman clinical study where 29% of the patients required a secondary re-excision.
Yes, they had to be cut open again because it was impossible to safely remove all the integrated offending mesh in one pass.
And what happens when the primary issue is profound skin stenosis? Like where the previous surgeon removed so much tissue or the scarring is so severe that there physically isn't enough material left to reconstruct a functional opening.
In those cases, the surgeon must introduce entirely new tissue to line the cavity. Historically, the gold standard has been a secondary skin graft.
From where?
The surgeon creates a large elliptical incision on the patient's abdomen, resulting in a scar very similar to a full tummy tuck to harvest healthy skin.
Okay.
They take that skin, manually cut hundreds of tiny slits into it to allow it to stretch and expand like a fishnet. Then they wrap it around a medical cylinder and surgically implant it into the newly opened vaginal cavity to heal and take root.
Which introduces a whole secondary site of surgical trauma on the abdomen.
Right.
But what's fascinating here is how the surgical technology is evolving to bypass that abdominal trauma entirely. The Translational Andrology and Urology Journal outlines a much more advanced technique called the robotic peritoneal flap revision.
What's fascinating here is that it is a massive leap forward in reconstructive mechanics.
How does it work?
Instead of harvesting external abdominal skin, surgeons utilize the peritoneum. That's the naturally smooth, highly vascularized membrane that lines the interior of the abdominal cavity.
But why harvest internal lining instead of external skin? What is the biological advantage?
Oh, the biological advantages are immense. The peritoneal tissue is naturally hairless, highly robust, and naturally lubricated.
And it eliminates the need for a massive, painful external abdominal scar.
That's exactly. But the most critical advantage is the robotic approach itself. Using robotic-assisted laparoscopy, the surgeon operates through tiny keyhole incisions with highly magnified, pristine 3D visibility deep into the pelvic basin.
Right, because when you are dissecting through a solid block of fused scar tissue, where the bladder and rectum are millimeters away, you need that.
That robotic 3D precision is the only thing preventing a catastrophic organ injury.
Here's where it gets really interesting, though. You read about a robotic-assisted internal peritoneal flap, and it sounds incredibly sleek.
It does.
It sounds like a hyper-modern silver bullet that guarantees a perfect outcome. But the actual data across these clinical papers paints a much darker, much more sobering reality about the physical limits of the human body.
The statistics force a very harsh reality check, unfortunately.
Yeah, the hard numbers from the translational andrology and urology data are impossible to ignore. Vaginoplasty procedures in general carry astronomically high revision rates, sitting anywhere from 27 to 60%. And when we look specifically at those secondary skin graft revisions we just discussed, one study reported an overall complication rate of 28.6%.
But the statistic that truly illustrates the cruelty of this complication is the restenosis rate.
The re-narrowing.
Right. After surviving a failed primary surgery, enduring months of conservative therapy, and finally undergoing a massive secondary skin graft revision, 22.9% of those patients experienced restenosis.
Over 1 in 5 patients healed from the revision surgery, only to have the new graft contract, scar over, and narrow the canal all over again.
Yes, they ended up in the exact same trapped state they started in.
That is heartbreaking. And then we have to talk about the 8.6% rate of rectovaginal fistula formation.
Yes.
Meaning almost 9% of the patients in that study sustained an injury during the revision that resulted in an abnormal surgical hole connecting their rectum directly to their vagina.
A fistula is a devastating, life-altering complication. It fundamentally ruins a patient's quality of life and demands even more high-risk reconstructive surgeries to repair.
So because the statistical probability of these complications is so high, specialized reconstructive surgeons impose rigid, non-negotiable biological disqualifiers.
Yes. If you don't meet the baseline criteria, they will flat out refuse to operate.
Let's walk through those hard limits. What completely disqualifies a patient from getting a revision?
Well, active smoking is an absolute immediate contraindication.
Because of blood flow.
Exactly. Nicotine aggressively constricts blood vessels. A newly implanted tissue graft relies entirely on a delicate microcirculation system to survive its first few days.
And if they smoke?
If a patient is actively smoking, that microcirculation is destroyed, and the newly implanted skin graft will simply turn necrotic and die inside the body.
Wow. Another hard clinical limit I saw was a hemoglobin A1C of 7% or greater, meaning if a patient has uncontrolled diabetes, the surgeons won't touch them.
Right. Uncontrolled blood sugar severely degrades the body's intrinsic cellular ability to close a wound and fight off bacteria.
That makes sense.
Operating on an uncontrolled diabetic in a highly complex, heavily scarred pelvic environment is an unacceptable risk for massive infection and total graft failure.
Are there physical history disqualifiers too?
Yes. If a patient is hoping for that high-tech robotic peritoneal flap, their surgical history might disqualify them. If they have a history of multiple open abdominal surgeries, the interior peritoneal lining is likely covered in massive adhesions and scar tissue.
Rendering it entirely unusable for a clean harvest.
Exactly.
So we have to talk about the ultimate finish line here. If a patient somehow navigates the psychological toll of the daily dilation, qualifies for the surgical revision, successfully undergoes the robotic reconstruction or the mesh excision, and miraculously avoids a fistula or a secondary restenosis,
A lot of hurdles.
It really is.
Right.
What is the actual expectation for their body at the end of all that?
The medical literature is adamant that both the surgeon and the patient must undergo a profound psychological shift regarding the outcome.
Managing expectations.
Yes. Revision surgery is an exercise in harm reduction and functional salvage. It is not about achieving anatomical perfection.
As the Miklas and more clinics make explicitly clear, you can radically improve flexibility. You can significantly reduce the sharp, tearing surface pain.
Right.
You can surgically engineer the canal to make penetration physically tolerable and functionally restore a massive portion of the patient's quality of life.
But a structural revision cannot undo microscopic nerve damage.
Right, the nerves.
If the primary surgeon severed or permanently crushed the deep pelvic nerves during the initial procedure, cutting away scar tissue will not bring those nerves back online.
So some pain might linger.
Some degree of altered sensation, numbness, or residual deep tissue discomfort will likely be permanent.
It is a profoundly heavy, exhausting reality for these patients to navigate. So to answer the core mission of this deep dive for you, the listener, can surgical tightening be revised?
Yes, but it is never a clean, simple undo button.
It is a grueling, multi-layered physiological battle that demands an agonizing gauntlet of conservative physical therapies, the intervention of highly specialized reconstructive experts, and a sobering acceptance that going back under the scalpel carries terrifyingly high risks of complication.
It is arguably one of the most demanding tests of medical endurance a patient can go through.
But before we wrap this up, we want to leave you with a final, mind-bending thought about where the future of this medical frontier is heading.
Oh, this is fascinating.
We spent a lot of time discussing the inherent trauma of having to slice open a patient's abdomen to harvest a skin graft just to fix a stenosis issue in the pelvis. It is a primitive solution to borrow flesh from one part of the body to patch another.
The absolute holy grail of reconstructive gynecological surgery is discovering a biological material that seamlessly integrates and heals without requiring a secondary donor wound on the patient.
And researchers are actively exploring some truly wild science fiction level biological alternatives to solve this. If you want to fall down an incredible research rabbit hole after this deep dive, go look up the experimental medical use of Nile tilapia fish skin as a biomaterial graft for vaginal reconstruction.
I know it sounds utterly absurd on its face, but the underlying biology is astonishing.
Right.
The microscopic collagen structure of sterilized, decellularized tilapia skin is remarkably identical to human mucosal tissue.
It's amazing.
It has already shown revolutionary promise in healing severe third-degree human burns, and scientists are now aggressively studying its application as a scaffold for gynecological reconstruction.
Or look into the accelerating development of 3D printed vaginal scaffolding. Imagine a near future where a surgeon doesn't have to navigate the risks of an abdominal skin harvest.
Yes.
Instead, they take a scan of your pelvic cavity, and our bioprinter generates the exact mathematically perfect scaffolding your body needs, seated directly with your own stem cells to prevent rejection.
It is the ultimate evolution of reconstructive surgery, entirely bypassing the complications we've spent this entire deep dive analyzing.
The diagnostic waters might be incredibly muddy right now, and the realities of revision surgery are unarguably harsh, but the technology to clear those waters and rebuild the human body without secondary trauma is actively being built in labs right now.
It's an incredible time for medical science.
It really is. Thank you for joining us on this highly complex, intense journey today. Keep questioning the consensus, keep learning about the incredibly resilient machines we live inside, and join us for the next deep dive.